everybody. My name is Judith Marion, and I'm one of the St. Paul's Kidney Care Clinic pharmacists, and as well the BC Renal KCC Vice Chair. So I would like to welcome all of you to our second KCC staff session for 2024, which has a very timely topic, talking about Finerenone, since this medication was just approved for coverage with PharmaCare in the last few months. So before we start our presentation, I acknowledge with gratitude that we're speaking to you from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nation. And just for housekeeping, I just invite you to ask questions through the chat function, and I will monitor and I'll make sure that we go through all the questions at the end of the presentation. So without further delay, it's my pleasure to introduce Dr. Mark Elliott. Dr. Elliott has joined the Division of Nephrology last year, and he's a clinical assistant professor based at St. Paul's Hospital in Vancouver. He serves as the lead for the Provincial Kidney Genetic Clinics, and he completed his internal medicine training at the University of Saskatchewan, followed by his nephrology training at the University of Calgary. He then completed a 3-year fellowship in precision medicine and genetic in nephrology at Columbia University in New York. His research focuses are on clinical outcome of patients with genetic kidney disorders, as well as the integration of genetic data into clinical care. So without further ado, thanks a lot, Mark, for doing this talk for us. And I'm sure that we might have an interesting discussion after. Thanks, Mark.
Perfect. Thanks so much for the introduction. Let me just share here. So as you've heard, there wasn't a lot of KCC mentioned there, but I do partake in a lot of our kidney care clinic here at St. Paul's. And so that's sort of the lens that I'm bringing to you for this presentation, outlining really the current management of Finerenone and our current sort of treatment paradigm with it. I also wanted to say thank you for joining for all of our nurses and all the great care you do. You deserve all the recognition that Nurses Week brings with it. So I hope you guys enjoy. The one piece that I do think is important for me to highlight is that I definitely do have a conflict here. I have received honoraria from Bayer, who makes Finerenone, so that is certainly present, but I've done my best to try to keep it out of the presentation for as much as possible. So what I'm hoping that we can talk about today is first go over our risks that are associated with chronic kidney disease and recognize that there's a residual risk that exists for our patients, even with modern standard of care therapies, and then talk about our guideline-based treatments we can implement specifically for our patients with chronic kidney disease and type 2 diabetes, because that's really the area where Finerenone is focused right now. So most of us as kidney care providers recognize what CKD is, focusing mostly on a GFR as well as an albumin to creatinine ratio or albuminuria. But there's actually quite a few different ways you can be diagnosed with CKD. So you can have persistent urine sediment abnormalities, which we see in a lot of our glomerular disorders. You can have persistent electrolyte or other abnormalities leading to tubular disorders. You can have abnormal structure of your kidneys, which is what we see in patients with, say, autosomal dominant polycystic kidney disease. And a lot of these are captured outside of our routine lab values of albuminuria and GFR. So I just think it's important to highlight that we have multiple different ways that we can get to a diagnosis of CKD for our patient population. And we've got a recent guideline that just came out on Kidney Day of 2024 that highlights sort of the cutting edge of CKD management. So if you're interested in that, that was put out by KDIGO, and it's a great resource to have. When we think about classifying our patients with chronic kidney disease, we'll typically use the CGA staging system, which we're probably all quite aware of. So we need to figure out the cause of kidney disease. We need to figure out a patient's GFR because that gives them a G bucket. And then we need to figure out someone's albuminuria, which gives them their A bucket. And this is the classic heat map that we must show at all presentations related to nephrology. And really it highlights that as your albuminuria goes up, so you move more towards the right, or as your GFR goes down, so you move closer to the bottom, our risk of kidney-related outcomes gets higher. So whether that be progression of CKD, whether it be AKI, whether it be other outcomes, albuminuria is an important feature and low GFR is another important feature. I also wanted to highlight just how prevalent these disorders are in the population. So obviously, as kidney care providers, the majority of almost everyone we see is going to have chronic kidney disease. But when we think about broader populations, these are very common disorders. So it's estimated that approximately 1 in 10 people within the world have chronic kidney disease. And this is something that's becoming more and more prevalent in our populations as our risk factors get more common, like hypertension, diabetes, obesity, and as we're having less people die from kidney failure. So our medications get better, our group of people living with CKD gets bigger. But despite that, it's one of the sort of already leading causes of death within the world, and that's only expected to get worse over time. So by 2040, it's expected kidney disease will be our 5th leading cause of death worldwide. To sort of put that in the context of other risk factors, type 2 diabetes is also a significant problem that we're dealing with. And already 1 in 15 people worldwide suffer from type 2 diabetes. And again, the prevalence of this is rising globally. When we look at our burden of chronic kidney disease, so this was a worldwide burden of chronic kidney disease published in The Lancet, we can see that our population of patients who are a bit older is really where the bulk of our patients with chronic kidney disease are. And the color-coded levels to this box highlight the cause of chronic kidney disease. And as we can see, diabetes, hypertension, and glomerular disease are our leading causes of CKD. I also really wanted to highlight that this, when you adjust for the population size at risk, really increases in our older age group. So really a minority of individuals less than 50 are affected by CKD. But as we get up into our 60s, 70s, 80s, it becomes very, very prevalent. When we look at Canadian data specifically about the overlap of CKD and type 2 diabetes, it's a significantly overlapping population. So about half of our patients with type 2 diabetes have some evidence of CKD in a large Canadian registry. So this is presence of either albuminuria, reduced GFR, or one of our other features that's suggestive of abnormal structure or function. When we look at what stage of CKD they're at, the majority of these patients are quite early stage. So with either microalbuminuria, seen on the bottom on that left box in black, or with a relatively preserved GFR in stage 1 or 2. But for us, the patients we're most likely to see in our chronic kidney disease clinics are those highlighted in those red boxes. So those with GFRs less than 60 or ACRs greater than 30. I highlight this because these are also our patients that are at the highest risk when we looked at our CKD heat map. So these patients, we know we're going to need sort of more aggressive care because they're going to be at more risk of poor outcomes. The other thing I wanted to highlight is that 1 in 4 to 1 in 5 individuals with type 2 diabetes have concomitant cardiovascular disease. And when we think about adding diabetes with chronic kidney disease with cardiovascular disease, we're starting to get a feel for how high risk these patients are and what risks we should be considering when we're seeing them in clinic. To give you an idea of what sort of that additive risk looks like for individuals, so your 10-year sort of incidence of mortality in the absence of CKD or type 2 diabetes for sort of a given older population is about 8%. But every time you add on one of those risk factors, be it type 2 diabetes, albuminuria, or reduced GFR, or the combination, we can see that our risk of passing away increases almost exponentially. And so really the patients that we see in our chronic kidney disease clinics are at very high risk compared to the average population. And I just think we need to keep that in mind when we're thinking about the care that we're providing to them. I showed you the heat map generally with its sort of color-coded risk factors, but this is a similar presentation of that same heat map with very similar categories of risk, but broken down by specific outcomes. So we can see that as our albuminuria increases and our GFR decreases, our risk of end-stage kidney disease, AKI, as well as progressive CKD all increase. And this makes sense. These are things that are drivers of progression, and so that was something that we would expect. But this also applies outside of kidney outcomes. So these 3 graphs show our ACR on our x-axis and our risk of 3 different cardiovascular outcomes, so cardiovascular death, myocardial infarctions, and hospitalizations for heart failure. And what we can see is that our albumin to creatinine ratio predicts these 3 cardiac outcomes quite well. So A lot of our patients who aren't followed in chronic kidney disease clinics or aren't seen by nephrologists oftentimes don't have UACR measurements done. And so this slide just really highlights the importance of including that, as it's a really meaningful prognostic indicator for our patients. When we think about sort of what leads to progressive CKD, there's a number of different factors that are all at play. There's hemodynamic effects due to high blood pressure and increased intraglomerular pressure. There's metabolic effects. So this is our glycemic end products that are related to having hyperglycemia. We've got inflammation and fibrosis that happens within different compartments of our kidney, ranging from the glomerulus to the tubular interstitial area. And all of these sort of work together to put a patient at risk of having CKD progression. Oftentimes what we'll see when we look at, say, kidney biopsies of patients with kidney disease is those end pathways, really no matter what the first cause of your kidney disease, tend to look pretty similar. So it's not that there's just a few pathways that drive these really significant end outcomes within our kidney histology that ultimately lead to CKD progression. And because of that, we're thinking more about sort of platforms of treatment for patients. So medications that are relatively disease agnostic that we can use in broad categories of people with chronic kidney disease that are hoping to aim at these sort of more common or more shared pathways towards fibrosis and progression. As sort of an idea of breaking that down into different levels of treatments that we can employ for our patients, KDIGO had a really nice pyramid created in 2022 that outlines specifically the treatment recommendations for patients living with diabetic kidney disease as well as chronic kidney disease. And I really like this because it really highlights the different levels that we should be focusing on. So at the base level of the pyramid, we have our baseline sort of lifestyle and non-pharmacologic management options that we should be employing in all of our patients with CKD and diabetes. So this is a healthy diet, regular exercise, smoking cessation, and weight management. And we know these are really meaningful for our patients. Those individuals who are able to make these lifestyle changes have huge benefits in terms of their quality of life, as well as their clinical outcomes. So I like that they put this as our baseline because it's really what everything else is built upon. One level up in our pyramid, we go to our medications that should be used in pretty much everyone who has these two disorders. So this is metformin as an initial treatment for their diabetes, adding on an SGLT2 inhibitor, which we'll talk about a little bit here. I have very strong evidence for cardiac and kidney protection, RAS blockade in the treatment of their hypertension or just their isolated albuminuria, and then statin therapy has been shown to be highly beneficial in patients with diabetes, although typically is for some reason the hardest medication in the world to get people to take. Built on top of that, we have therapies that are beneficial for subsets of individuals with specific indications. So we've got our GLP-1 agonists. So this is like semaglutide. There's a big study being released at the European Society of Nephrology conference later this month, looking specifically at semaglutide and kidney-related outcomes called the FLOW trial. That trial was stopped early due to an interim analysis showing that it was superior to be on semaglutide compared to placebo. And so I actually suspect that our evidence base for GLP-1 agonists is likely to move down our pyramid, and that it's going to be more broadly applied. But that data hasn't been released yet, so it stays where it's at for now. We've got antiplatelet therapies, so like aspirin for specific individuals at high risk of atherosclerotic cardiovascular disease. And then we've got our newer agents on the block like non-steroidal mineralocorticoid receptor antagonists or MRAs, which is where Finerenone fits in. At the top of the pyramid is focusing on those other things that we do at chronic KCC clinics, as well as in our outpatient practices, which is glycemic control, blood pressure control, and lipid management. We know these are really meaningful in certain contexts, and so that's why they sort of live at the top. Because really, if you're doing a lot of the bottom stuff, your top part's probably going to be relatively well managed off the gate, and then you're just going to need small tweaks there. So with that, I wanted to move into a case to sort of frame the rest of our discussion. So this is Elizabeth, and this is a typical patient who we would see at our chronic kidney disease care clinic here at St. Paul's. She's 68. She has a diagnosis of chronic kidney disease in the setting of type 2 diabetes, which was diagnosed 6 years ago. But from speaking with her, it's probably been much longer standing than that. Her blood pressures are at our target of less than 130/80. Her hemoglobin A1C is well controlled at 6.9%. Her LDL is at target at 1.65, so less than 2. and her GFR is 29 with an ACR of 86. So she's a G4A3 patient if we're going to stage her through our staging system. The medication she's on looks pretty good for our second level of our pyramid. So she's on a atorvastatin, she's on dapagliflozin, she's on metformin, she's actually on semaglutide, which is great, and she's also on perindopril. So she's got our whole baseline of our pyramid covered. So the next question is sort of what is her risk going forward and what can we do to help her out even further? So looking at our heat map, when we put her onto here, as I said, she's in G4A3, which puts her in the very high risk of kidney and cardiovascular risk. And I'm sure a lot of you in your chronic kidney disease clinics are using the KFRE to figure out patients' risk of progression. And when we fill in her KFRE, it's relatively high. So 9.5% risk at 2 years of kidney failure and about a 26% risk at 5 years. So again, a typical patient we'd see in our KCC. Bringing back our pyramid of management. So we're so lucky in kidney care clinics to have access to the time to counsel patients regarding our lifestyle management. We've got access to our dietitians who are so much more adept than I will ever be talking to patients about dietary interventions. And so thanks to our model, we're doing a good job of managing this non-pharmacologic level of our pyramid. Additionally, as I said, we're doing all of our first-line drug therapy really well. Again, it's so nice to have the help of our pharmacists who are so adept at getting access to patients to these medications and for flagging patients who could have specific therapy started. For her, she's also on a GLP-1 receptor antagonist, which is excellent. And as we saw, all of her risk factors are well controlled. So really, it leaves us not a lot to focus on in terms of optimizing her care. But she still has persistent albuminuria, which continues to put her at risk of adverse outcomes. So it makes us wonder if there's things we can do differently. When we think about sort of those mechanistic factors that lead to progressive chronic kidney disease, focusing on the hemodynamic, the metabolic, and the inflammation and fibrosis, these are the places where our known medications really work already. So ACEs and ARBs and SGLT2 inhibitors work really well for our hemodynamic, inflammation and fibrosis and our metabolic factors. And then our other diabetes medications like GLP-1 agonists and things like metformin are really good at helping with that metabolic features. This is really built on decades and decades of research. And so I wanted to go back and give you an idea of sort of what a breakthrough things like ACE inhibitors and ARBs were when they first came out, and why there's been so much excitement around new medications like SGLT2 inhibitors for patients with diabetic kidney disease. So going back to 2001, when the collaborative study group released this seminal paper studying irbesartan compared to amlodipine or placebo, in individuals with type 2 diabetes, hypertension, and chronic kidney disease, what we were able to see was that there was a significant difference between the lowest line in each of these clinical outcomes, which is irbesartan, when compared to either amlodipine or placebo. And these are sort of primary outcomes as they relate to kidney outcomes. So it was doubling of serum creatinine, end-stage kidney disease, or death. And you can see that the sub-Kaplan-Meier plots are broken out by each of those individually. So there was in the top right a reduced risk of developing end-stage kidney disease. In the bottom left, a reduction in doubling of serum creatinine. And in the bottom right, not really any signal driven there by death from any cause. So certainly most of our kidney-related outcomes are being impacted by starting patients on ACE inhibitors and ARBs. But the problem that we're left with is, even at just 54 months of follow-up, the residual risk of having one of those poor outcomes was about 50%. So still half of our patients, despite receiving irbesartan, were developing an adverse outcome in regards to their kidney function. So it really left a huge gap for treatment to be available. And we're really lucky because we now have a couple of different options. The most prominent one that I'll talk about next is going to be our SGLT2 inhibitors. And as the data is developed for SGLT2 inhibitors, we've seen that their indications have just gotten broader and broader. So the early trial in diabetic kidney disease was Credence, so it focused on patients with a GFR between 30 and 90, and significant amount of albuminuria, so an ACR greater than 30 in R units. And so you can see that's a relatively high risk group of patients. The next study that was reported was DAPA-CKD, which actually lowered our albuminuria cutoff somewhat to 20 and lowered our GFR cutoff a little bit to 25. So this broadened our indications for using SGLT2 inhibitors for our patients. And then probably our broadest trial to date was EMPA-KIDNEY, which included individuals with a GFR of 20 to 45 and any amount of albuminuria, even none, and in addition to a relatively higher risk group with a GFR of 45 to 75 and over 20 milligrams per millimole of urine albumin to creatinine ratio. So that overlaps very closely with what we saw in DAPA-CKD. So we can see that the vast majority of our kidney heat map is now covered by one or another SGLT2 inhibitor trial. And why that's so important for us to know as care providers is these drugs really significantly impact kidney-related and cardiac outcomes. So focusing on Credence, which used canagliflozin, in patients with confirmed type 2 diabetes, we saw a 30% reduction in renal outcomes, 20% reduction in 3-point MACE, significant reductions in cardiovascular death and hospitalization for heart failure, and a non-significant but quite large trend towards a reduced all-cause mortality in this population. So all really strong hard outpoints that our patients really care about. Moving next to the DAPA-CKD trial, which used dapagliflozin, which now is generic, so it's much cheaper and much more accessible for most of our patients. We again saw significant impacts on kidney events, cardiovascular death and hospitalization for heart failure, and actually reduction in all-cause mortality in this population. We didn't see the MACE outcome here, but the other studies looking at dapagliflozin and other sort of high-risk cardiac populations have shown benefits. So it's not really something to worry about. And then the last one that I'll talk about is EMPA-KIDNEY. Again, this was the broadest inclusion pretty much across the board. We see very similar beneficial outcomes to using these medications. So this is why a combination of ACE inhibitor or an ARB and an SGLT2 inhibitor is really standard of care for all of our patients with diabetic kidney disease, and likely lots of patients outside of that population as well with vast different causes of kidney disease. One of the things I wanted to highlight is that although these medications are really, really helpful to start later on in a clinical course where we know that they make a difference, we think that they're probably going to be even more beneficial if we can start them earlier on. So this was a nice study that used some modeling to try to figure out what the benefit to the addition of an SGLT2 inhibitor would be for a 70-year-old patient with diabetic kidney disease based on what their initiating GFR would be. So if we started a GFR of 30, these drugs work really well and we're likely to delay their need for dialysis or a kidney transplant by about 3 years. Alternatively, if they have a GFR of 70 and we're able to start these medications, we actually delay their need for dialysis or kidney transplant by about 11 years. So that's a really meaningful difference. And so I bring up this slide to really highlight that the earlier we can get these medications started, the longer the patients are on it, the more benefit they're going to accrue over time. So when I'm talking to my colleagues outside of nephrology who are caring for patients who have better GFRs than I'll ever see, this is one of the things I really like to highlight, is that their vigilance and them staying on top of these new drugs and starting them for their patients makes a way bigger impact than me starting these medications quite a bit later in a patient's course is ever going to have. And these trials were amazing. As I said, we've reduced patients' risk significantly across the board, but we're still left with a fair bit of residual risk. So canagliflozin, the residual risk of having an adverse kidney outcome at 2.6 years was still 11%. That's still quite high. DAPA-CKD, 12% at 2.5 years. EMPA-KIDNEY, 15% at 2.5 years. So there's still quite a gap despite optimal medical therapy where these patients are still experiencing poor outcomes. So it leaves the gap for something else to come in here and help patients out. The other thing I wanted to highlight is that despite these medications being highly effective, we know they're underprescribed and underutilized in the Canadian context. So this was, again, looking at data from about 15,000 individuals with type 2 diabetes and chronic kidney disease of various stages. But we can see that the utility of, or the use of these drugs in clinical practice is actually quite low. So my two red lines highlight an 80% of patients being on that medication, and then a 50% of those patients being on that medication. And you can see we only reach 80% of individuals on an ACE or an ARB in CKD stage 2 and stage 3A. But really our other medications that we have seen have huge impacts, like SGLT2 inhibitors, we're at best looking at about 60 to 65% for certain stages, and that really trails off. So now we've got a lot of work to do in terms of getting our patients on the correct medications, even without anything new being available. So this talk is obviously focusing on Finerenone based on the title, and so I just wanted to introduce its role in terms of this whole idea of our treatment paradigm. So Finerenone is a non-steroidal mineralocorticoid receptor antagonist. It has specific anti-inflammatory and anti-fibrotic effects that are based on what's known about aldosterone's impact on the kidney. So we think that it acts here. We also know that these medications are actually quite effective antihypertensives, especially in individuals who have resistant hypertension. So there's likely a hemodynamic impact of this medication as well. So again, giving us more tools in our toolbox to treat different parts of the CKD progression pathway. And Finerenone is a little bit unique in terms of a molecule because it falls into the class of mineralocorticoid receptor antagonists, of which we have a few, but it does have some specific differences which make it potentially more tolerable for our patients and maybe more efficacious. So our traditional mineralocorticoid receptor antagonists are steroid-based. So that's spironolactone and amplirenone. And because they're steroid-based, they have a high chance of sort of cross-reactivity with other steroid-based receptors. So this drives really a lot of our sexual side effects that we see with spironolactone, like our gynecomastia and those sort of effects. And it's thought that the risk of hyperkalemia is quite a bit higher with these medications. Finerenone is actually non-steroidal based and is a different shape than these other molecules. So because of that, it has a lot less off-target binding, and we think is highly selective and highly potent for the mineralocorticoid receptor, leading to a reduced risk of hyperkalemia, and again, less of those side effects that we talked about. So Finerenone's been studied in a couple of contexts within chronic kidney disease now, focusing mainly on 2 studies. These studies were in patients with type 2 diabetes who had known chronic kidney disease. They had to be on optimized RAS inhibitors, which was an ACE inhibitor ARB at maximum tolerated dose, with a normal serum potassium of less than or equal to 4.8. You'll notice that SGLT2 inhibitors are not mentioned within the criteria because they really weren't standard of care when the trial was started. And individuals with symptomatic heart failure with reduced ejection fraction were excluded because those patients had an indication for either amplirenone or spironolactone based on prior evidence. So it wasn't felt that it was reasonable to randomize them to not receiving an MRA. The first of this pair of studies was called Fidelio. It focused on kidney disease as its primary outcome and had a secondary outcome of cardiovascular outcomes and looked at Finerenone versus placebo on top of that standard of care. What Fidelio was able to show, which we'll go into in a little bit more detail, was there was a significant slowing in the progression of CKD and an improvement in most of our kidney and cardiac related outcomes. The second pair of these trials, as you can see, focuses on a lower risk population and looked at cardiovascular outcomes as its primary outcome, but had a secondary outcome of kidney outcomes which matched Fidelio. So Figaro is a heart primary and a kidney secondary. Fidelio is a kidney primary and a heart secondary. And they designed it like this so that they could cross-analyze the 2 trials together to increase the sample size and the statistical strength of any of the associations that they found. Figaro did show that the primary outcome of cardiovascular outcomes was reduced as well using Finerenone. So both of these trials were positive in them, right? So there's a large population that this was studied in. So it's pretty much anyone with a GFR above 25 who had albuminuria over 30 milligrams per millimole, and many patients, so 25 to I think it's 90, who had just moderately increased albuminuria, so greater than 30. So this again is quite a large population that we've looked at. Getting into a little bit of the specifics here, Fidelio was our study of kidney-related outcomes. So again, it was patients with type 2 diabetes and chronic kidney disease, either reduced GFR and minimal amounts of albuminuria or a more expanded GFR cutoff with higher amounts of albuminuria. Again, as I said, treated with maximal tolerated standard of care medications, and then randomized to Finerenone versus placebo. The Finerenone starting doses were different based on patients' baseline eGFR. So those with a GFR above 60 received 20 milligrams per day to start. Those between 25 to 60 started at 10 milligrams per day, which was up titrated if they did not develop hyperkalemia. And this is what I would recommend doing in practice as well. Treatments were held if potassiums were greater than 5.5 and were restarted if people developed normal kalemia thereafter. As I mentioned, Fidelio had a kidney-related primary outcome, as you can see there, and a secondary outcome that was heart failure. When we look at the cohort themselves, it's pretty typical for the patients we would see here in a KCC. So the average age was 65.5, predominantly male, good proportion of individuals who are non-white in terms of self-reported ancestry. Everyone had diabetes, and they had diabetes for approximately 17 years with relatively good glycemic control. Systolic blood pressures, as you can see, were pretty well controlled, and a mean GFR of 44 with a mean ACR of 85. So this is a classic patient who we would see. And before treatment, the mean potassiums were both 4.4. We look at baseline medication use. You can see almost everyone was on an ACE inhibitor or an ARB. Over half the individuals were on a diuretic. 75% were receiving a statin. About 2.4% of people received a potassium-lowering agent, so that's going to be one of our binders. And then, as I said, SGLT2 inhibitors and GLP-1 agonists were used in just a minority of individuals. So when we compare the use of medications here to what we saw in a big Canadian cohort, probably these patients were on better standard of care therapy than the average patient with diabetes and CKD within Canadian populations is. So yeah, their baseline risk in the study might actually be lower than our baseline risk because of that. So what Fidelio looked at was, again, that kidney primary outcome, and we can see that there was a statistically significant reduction in its risk, as well as for the cardiovascular outcome, there was, again, a statistically significant reduction in the risk of secondary cardiovascular outcome. So a really nice study that showed that there was a benefit to adding Finerenone onto our other medications. They looked at the reduction in urinary albumin to creatinine ratio, which we know is an important marker of treatment response, and there was a 31% reduction in that, and a really minimal change in our serum potassium. So there was a 0.23 millimole per liter increase over the course of the trial in the group who received Finerenone compared to those who received placebo. So quite a small change in our serum potassium. To give you numbers of patients who had to discontinue the medication due to hyperkalemic events, 21.7% of the individuals had a potassium over 5.5, and then 4.5% had a potassium over 6. But you'll have to remember this is in the absence of SGLT2 use, which was shown in the study in a smaller subset to significantly reduce the risk of hyperkalemia. So with combination therapy with SGLT2 plus and non-steroidal MRAs, we're probably going to see less hyperkalemia than they saw in the study. For Figaro, which is the study that focused on cardiovascular outcomes, again, it was patients with type 2 diabetes as well as chronic kidney disease, but we saw that the GFR cutoff was a little bit higher than we used for other populations. So we didn't capture quite as low of GFRs, especially in those albuminuric patients. Again, the treatment randomization was the exact same, and our clinical outcomes are just flipped. So we've got our primary outcome is cardiovascular outcomes, and our secondary outcome is kidney-related outcomes. And very similar to what we saw in Fidelio, Figaro showed a positive signal of benefit in our cardiovascular outcome, and there was a just slightly non-significant trend towards a reduced risk of kidney outcomes within this this study population. So, as I said, this was a lower kidney risk population, and because of that, they did not find a statistically significant association. The nice thing about designing the trials this way, which was really smart from the outset, is because they're so compatible, they'd actually planned a pooled analysis of these two trials from the very beginning. So Fidelio had about 5,700 individuals, slightly higher kidney risk with a kidney-related outcome as the primary. Figaro had a cardiovascular outcome, again, slightly bigger, but slightly lower kidney risk. And they actually combined these into what's called the fidelity analysis, which was a pooled analysis of both kidney and cardiovascular outcomes from both of these trials. The fidelity analysis looked at sort of an actually more difficult to reach clinical outcome, which was kidney failure or a 57% decline in your eGFR or death from a kidney-related cause. And And what we were able to see was that there was a 23% relative risk reduction or a 1.6% absolute risk reduction. So that's a pretty significant benefit that we can see on top of standard of care therapy. Now, this is combining quite a large group of individuals, some with quite good GFRs, some with GFRs down to 25, some with severe albuminuria, like 303 grams per day, some people with very minimal amounts of albuminuria. So went down to sort of 3 milligrams per millimole. So one of the nice things that they did in the study was look to see if any of those GFR or ACR cutoffs interacted with the benefit of Finerenone. So trying to identify a population that didn't benefit from the medication. And what we can see is that pretty much across our GFR boards, we can see that the relative risk of developing a kidney-related outcome is pretty stable. So that's what we can see sort of looking at this graph. It's consistently less than our sort of mean level of 1, which would show no benefit to Finerenone. So this is suggesting that across our GFR categories, we are still seeing that benefit. For our ACR categories, very similar trend is seen, although there were smaller numbers of individuals with low levels of albuminuria, and so this difference is quite small. You can again see that with the quite large error bars here and a movement towards the mean. But there was not a significant interaction here based on urinary albumin to creatinine ratio, and so there's not enough signal to say that these groups didn't benefit. So we think that it's applicable across the spectrum of kidney disease. Again, in the combined analysis, looking at the change in UACR, I can see that there was a 30% reduction compared to placebo in those who received Finerenone. And in our now classic GFR graphs, we can see that there's this initial hemodynamic decrease in GFR when the medication is initiated, very similar to what we see with ACE inhibitors, ARBs, or SGLT2 inhibitors. And then there's this chronic slope that's actually less steep compared to receiving placebo. And that's really the time where patients are accruing this benefit. So the mean difference in slope here for the chronic slope was just over 1.2 mils per minute per year. So that's quite a meaningful difference in terms of being on this medication for years and years and years. When they looked at cardiovascular outcomes in the Fidelity combined analysis, again, quite a significant reduction in cardiovascular outcomes seen with Finerenone, again, suggesting this medication has cardiac benefits as well. Looking at those other side effects or adverse effects, so blood pressures were actually a little bit better on Finerenone, like I said, so systolic blood pressure dropped by about 3 millimeters of mercury. There was no effect on hypoglycemia risks. Really no sexual side effects identified in the study, which lasted for a few years, with rates very comparable or lower than placebo. And there was actually a increased risk of hyperkalemia, but very few of the patients had like long-term discontinuation of the medication. So very few patients led to hospitalization, as we can see here, just 1.4%. Only 2.4% had permanent discontinuation of the medication. Now, that's obviously significantly higher than our placebo groups, but our absolute risk is quite low. On the right is our patients with preserved GFR, and we can see that these risks are even quite a bit lower. And then again, as I said before, that risk with SGLT2 inhibitor use is even further reduced. So there are things we can do to try to help. This was a study that I just saw at CSN last week, and it's a really nice analysis that looks at our different studies of SGLT2 inhibitors, GLP-1 agonists, and Finerenone, and looks at what the benefits to our patients would be if we added all these medications together. So what we can see is that on top of using an ACE inhibitor or ARB backbone. So what we can see is that adding just an SGLT2 inhibitor has a pretty significant impact. GLP-1 agonists have a small impact, although I think with flow being presented soon, this is probably going to move to the left towards being more beneficial. And then a benefit seen with non-steroidal MRAs. As we add on medication classes iteratively, we can see that the benefits our patients accrue continue to add up as well, to the point where having a patient on all three is thought to reduce their risk of developing a primary kidney outcome to by about 60%. So their hazard ratio is 0.42. What this correlates to is an absolute risk reduction of about 4.4% and a number needed to treat of just 23 individuals to prevent a kidney-related outcome. This very similarly holds true for all-cause mortality, where there's a number needed to treat of 33 for reducing to death. and for all of our cardiac outcomes. So looking at MACE, we can see again a 4.4% reduction in absolute risk and a number needed to treat of 2.3%. So our combination of therapies are having a really meaningful impact on patient outcomes. And it's something that we need to be aware of and really try to help our patients to understand what the point of these medications are. Yes, we're prescribing them for kidney disease, and yes, they're helping with that, but they have broad impacts as well, and they work together to reduce a patient's risk. So it really is sort of a holistic approach that we should be taking instead of a very piecemeal approach. So with that, as I'm sure you all know, and Judith said, Finerenone has become available here in British Columbia through special authority. The patients who we should be using it in is individuals with type 2 diabetes, those with a GFR greater than 25, those with normal potassiums, and those with albuminuria. So right now, there's no studies in Finerenone outside of individuals with type 2 diabetes, but this is a population that they're looking to study in the near future, very similar to what we saw happen with our SGLT2 inhibitors, where there was a sort of creep in terms of individuals included in studies as time went on in order to ensure that the broadest group of patients possible were able to benefit from these medications. So this is where we currently stand. And the nice thing about the special auth form is it really highlights those individuals who should be on this medication. I really should have pulled it into the presentation, but I didn't think about that till right now. But as you're checking off the checkboxes, it really highlights exactly who are included in Figaro and Fidelity. I've talked about the FLOW trial a couple times, and as I said, the results are due at ERA. So it was a randomized controlled trial of quite a few individuals, just over 3,500 with both diabetes as well as chronic kidney disease. A pretty standard inclusion criteria based on GFR and ACR cutoffs, and randomized individuals to semaglutide or placebo. As I said, this was stopped early, and the news report from the company that makes semaglutide that was released stated that there was a 24% reduction in the primary composite outcome, which, as you can see on the slide, was kidney failure, persistent 50% reduction in GFR, death from kidney failure, or cardiovascular death. So all really hard outcomes that are really meaningful to prevent in our patients. So I'm really excited to see the results of this presented at ERA, because I think it's going to be the next thing that will change our practice. Whether we can get access to this medication for our patients or not remains to be a different problem, but it's really exciting to have a number of different options available here. So with that, I'm very happy to open up the floor to everyone so that they can ask questions. I'll try my best to answer.
Thank you so much, Mark, for this very thorough overview of all the different options that we have for our kidney patient right now. Just because, I mean, as a pharmacist, I try to as well do counseling on all these different options. Like, what are some tips that you can give to the allied healthcare working with you in terms of adoption of polypharmacy for these patients? Because before we only had basically RASI to try to decrease progression, but now we have multiple, and that increase their like it's just increasing their polypharmacy quite a lot.
Yeah, it's a really good point. One of the things that's really nice is they're relatively easy medications to take. So SGLT2 inhibitors are once a day, Finerenone is once a day, and they can be combined with your other medications. So these patients are typically already on an ACE inhibitor or ARB. So if they're taking it in the morning, it's just an extra pill to add with that when it's not BID dosing or TID, which makes it really hard for patient adherence. So highlighting that part makes it quite a bit easier for patients. And then I always talk to them about sort of the benefits that we can follow. So we can measure their urine albumin to creatinine ratios after starting these medications and see the benefit. Lots of patients really find that a meaningful outcome, because hard outcomes like cardiovascular death and kidney failure are quite abstract to try to put it to the context. But your ACR going from 80 to 50 or 80 to 40 is really clear to see. And so that's the other piece. If people are sort of on the fence, we'll say, we'll try it, we'll see how it works. We'll probably see this ACR reduction, and then that really helps quite a bit. Unfortunately, we're stuck with medications as the other part. Like, lifestyle modifications are amazing, but for so many patients, they're just not able to make it happen. for a whole variety of reasons. And so oftentimes we're still working on that piece, but if we're stuck or not making the progress, then I sort of frame these as something to do in addition to that, to try to get them something else that's going to help out in the meantime. Yeah.
Great. We have as well a question from Jocelyn Conley in the interior. Would you choose these drugs over better blood pressure control?
Yeah, it's a good question. I try not to choose between. It'd be really nice to choose both. The nice thing is almost all of them have a blood pressure benefit. So SGLT2 inhibitors, we know due to the natriuresis improve blood pressure. Finerenone in the general population that was studied reduced blood pressure systolic by over 3 millimeters of mercury. There was a nice study of individuals, a sub-study that was never published, but looked at degree of hypertension and blood pressure response to finerenone. And it seems like, as we would expect, individuals with worse hypertension have a bigger blood pressure response to finerenone. Likely because a lot of those patients are going to have aldosterone-driven hypertension anyways, and it's still an MRA. So the same way that spironolactone is an amazing blood pressure medication for those with resistant hypertension, the data seems to suggest finerenone is also going to work really well for those patients. So you're probably going to see a pretty good benefit. And I know in my population that I've used it for, I've been pretty surprised about the blood pressure effects. It's tough because we know getting a patient with diabetes to a blood pressure of 130/80 does significantly increase their or reduce their risk of adverse events. We know that adding calcium channel blockers to ACE inhibitors, ARBs, is our first line treatment for hypertension in people with diabetes. But our other medications really don't have as much hard data on clinical outcomes. So I think it really becomes a sort of choose your own adventure. And my practice has been to add on our medications that have demonstrated clear cardiac and renal benefit. And then if we've got them on the whole mix, it's quite uncommon for us to have to add a lot of other blood pressure medications. But then if we do need to add something, it's typically only one or two more agents that we add in. So whether that's a diuretic, which we know is going to be helpful with the caliuresis and helping to prevent hyperkalemia, the calcium channel blockers, like I said, from sort of like Accord and Accomplish that showed some benefits there. So that's been my approach.
Thanks, Mark. And there is a follow-up question to that, to whether or not lowering BP versus adding agent, for example, lowering ACE or ARB dosage to try to optimize K to allow or be able to add finerenone. Can you comment on that?
Yeah, it's a really good question. So we don't have any data to guide us. So the trial was in individuals who were on max dose RAS inhibition without hyperkalemia, and finerenone was added. As you saw, the majority of patients were actually able to do something to keep them on their finerenone without developing persistent hyperkalemia. So whether that was adding an SGLT2 inhibitor, adding a diuretic, adding a binder, only 2.4% of individuals in the finerenone arm had to actually discontinue it due to persistent hyperkalemia. So I think the tools that we have in our standard practice are going to be adequate for the vast majority of individuals. In those 2%, probably what I would do is try low dose finerenone, so go with the 10. There wasn't really, well, I haven't seen any data to suggest there's a dose dependent effect. So try the lower dose and see if that leads to less hyperkalemia. But I probably wouldn't be backing off of my ACE inhibitors or ARBs based on the data we have now, because that's not how the trials were done.
I'll just open the floor if anybody else has any questions. Sounds good. Well, thank you very much, Mark. We're giving to everybody 10 minutes of their, oh, wait, there might be another question. Okay, if medications improve other factors or of CKD, if medication improve other factors of CKD, would the other direct medication, would you reduce other medication if these ones?
Yeah, it's a really good question. So I think what you're trying to describe is like someone goes from an ACR of 30 or 40 where they have an indication for all of these medications. We start them on an ACE inhibitor, we start them on an SGLT, we get them on finerenone, and their ACR is now 2, where they would no longer be included in those trials. Absolutely, we continue the medications. That's the goal of this. We actually know that those individuals who have an ACR response to these medications are typically the ones that benefit when you do a patient level analysis of this data. And so those are the patients where we're probably having the biggest impact. So totally would continue them at the maximum tolerated dose. If they're not tolerating them, so if they're having hypotension or persistent hyperkalemia, maybe that's getting back to what Jocelyn was bringing up. So maybe that's where we drop their ACE or their ARB a little bit and see if that helps. But outside of that, yeah, I would continue them.
Thank you so much, Paul, for the questions. So I think based on this, I think we're going to close the seminar. Thank you so much, Mark, for your time, and thank you all for spending your lunchtime with us. Wishing you a good day.
Thanks.
Bye.